Part 2 of Neonatology. Andy, Rennie.
Hi, everybody. Can you guys hear me? I hope.
Yes, I can hear you.
Okay, good. Thanks,
Yes,
Sam.
You're
Okay.
welcome.
Sounds good.
Okay, thank you. Okay,
I'm
everybody.
better this time, Brandon. Bye.
Okay, so we're going to continue with neonatology, and we're going to pick up at slide 74 with thermoregulation. So thermoregulation is a balance of heat production and heat loss. Unfortunately, newborns do not have the ability to maintain their own body temperature right away. So we need to do that for them. One of the things for those of you that are firefighters out there, you guys have all probably been taught how heat dissipates. But putting a naked baby, a naked wet baby on a wet blanket in open air will cause their body temperature to drop significantly quickly. So we need to dry them, stimulate them, and keep them warm. For those of you that don't know me, I don't have a whole lot of hair up on the top of my head, so neither do most babies. So putting a cap on them and making sure they're not losing their heat through their head is vitally important. Average normal body temperature of a newborn is somewhere in the neighborhood of 37.5 degrees Celsius, so a little bit lower than 98.6. Okay, non-shivering thermogenesis, production of heat by metabolism, not by shivering. Primary source of heat production in the neonate is by thermogenesis, and they, like I said, they don't shiver a whole lot. The brown fat located in their back, underneath their arms, is thermogenic tissue unique to a newborn. And there's one of the multiple differences between kids and adults, but especially in newborns, brown fat helps with temperature. And here are the 4 mechanisms which I was referring to earlier for you firefighters out there. The loss to the environment through one of the 4 mechanisms: evaporation, convection, conduction, and radiation. So again, the big one is evaporation and conduction. When you have a baby that is out there open to the air, the moisture on their body will start to evaporate, which pulls the heat with it. And also laying them on something that's cold and wet is conduction. So it's very important to keep them warm and dry. Fever, rectal temperature greater than 38 degrees Celsius. Their temperature regulation system, as we said before, is relatively immature. May not always be a presenting feature when infection or illness, like we see in older children and adults. You know, we have that patient that is tachypnic, might be hypertensive, hypotensive, but they have a fever. Their skin may get red, may have increased shortness of breath. With babies and newborns, they don't always have that fever feature when it comes to something that would be like, say, sepsis. So it's important to monitor their temperature. Identify serious bacterial or viral infections, which is not something we can really do pre-hospital, but if in the absence of a fever, if everything else fits, then it most likely is some type of infection. Overheating can easily become too hot. Dehydration is an important consideration, especially in breastfeeding babies. Limited ability to control their temperature, like we said. Like I said earlier, they don't sweat a whole lot because their temperature regulation system really isn't in place or still developing, especially if they were born a little early. That's even more delayed. So the sweating actually allows the body to cool itself. And it also shivers to raise its own temperature. So, and again, babies don't always have that ability. When fever is suspected, observe the newborn for presence of rashes. You can see that rash on the picture right there, also known as purpura, but it's a fever rash. Make sure you get a good history, get vital signs, remove any additional layers of clothing to improve environmental ventilation, cool the baby down as best you can without making them hypothermic. And here we go, hypothermia. Obviously, is a definition of drop in body temperature. It can occur in all climates. I often talk about the elderly in July walking down King Street in Lancaster with sweats, a hat, a coat. The elderly often lose their ability to regulate their own heat as well. And how many of you have grandparents that keep their furnace on every day of the year? Everything's always warm. So risk factors for hypothermia: all neonates are at risk within the first 8 to 12 hours after birth. A home delivery, just because it's a home delivery, and most people don't realize that most new parents, or say the Amish, or those that have babies at home, may not realize that temperature control is vitally important in the first couple hours of life. Prolonged resuscitation, keeping the chest open, doing CPR, keeping the head open for intubation, but still trying to keep them warm can prove to be difficult. If the baby is small for gestational age, say less than 5 or 5.5 pounds, there's a risk factor for hypothermia. Any infant that has a CNS or central nervous problem, obviously prematurity, which we just talked about, sepsis, and inadequate measures to keep the infant warm during transport, or after mom delivers, there's usually an awful lot of fluids or blood on the bottom of the litter. So it's important to either get that off or get it out of the way and put a dry surface down that you're going to lay the baby on, rather than on that wet area. They do have an increased surface area to volume ratio. They're extremely sensitive to environmental conditions, so it would not be unreasonable to have the heat on in the back of the ambulance in the middle of the summer to make sure we have a warm environment. Increase in metabolic functions to overcome the heat loss. So as baby starts to breathe on its own and circulate its own blood, in some cases we can get baby's temperature up somewhat, but it's important to have that balance. Hypothermic neonates are usually cool to the touch. Initially in the extremities, they may be pale, or may have some type of acrocyanosis or some blue tinting to it. They may be lethargic and somewhat obtunded. It looks like somebody who has an altered mental status, but it's coming from the lack of proper temperature. Some preventative measures that you can employ: warm your hands before touching the baby if at all possible. Dry the newborn thoroughly after birth and remove any wet blankets. Place a cap on the baby's head. Placing the infant skin to skin with the mother will help regulate, or help with that body temperature, at least until the second ambulance arrives. And I would say 99% of us already do not have pre-warmed incubators out in the field, unless you work for a critical care transport team like at Penn State Hershey or AI DuPont, but that's not usually something that we can have. Hypoglycemia. In full-term infants or preterm infants, blood glucose level of less than 40 milligrams per deciliter is what we're looking at for treatment. In adults, children and adults, we're looking at 60 and above. So there's an imbalance between the glucose supply and the utilization. may result in seizures and severe permanent brain damage. This is a vital time in the baby's development, as right after birth, is to make sure you check a blood glucose and make sure it is above 40. If not, obviously contact medical command, and you may have to initiate vascular access and administer D10 IV or IO. Glycogen deposits, receives glucose from the mother in utero, begins to utilize these stores to meet the glucose needs after birth, and most have stores for first 8 to 12 hours, and then metabolic adaptations are regulated by the hormones itself from the liver, and the pancreas, I'm sorry. So it's important to, again, make sure that we don't deplete the glycogen stores and deposits, and we check blood sugar. Symptoms of hypoglycemia, cyanosis, apnea, irritability, poor sucking or feeding, and hypothermia. Associated with lethargy, tremors, twitching or seizure-like activity, and coma or altered mental status. May also have tachycardia, tachypnea, and or vomiting. Management obviously would include blood glucose levels. Medical command may order D10 and obviously maintain a good body temperature. Vomiting is not an uncommon thing in newborns because they are just in the process of learning how to ingest something. They've never really eaten before. Their lungs and their belly and a lot of things have been full of amniotic fluid for the last 9 months, and they've now expectorated that out. And vomiting might not be something that is unusual to them, but they do, have a large amount of these babies will vomit within the first week or so of life. Here, according to 85% will vomit at least once during the first week of life. 10% have vomited by 6 weeks of age. They can simple spitting up. If any of you who have children, still getting used to formula and breast milk, all the whole way up to projectile vomiting across the room. Most of these episodes are benign. However, I can tell you from personal experience with my children, and I have a set of twin grandchildren, both born a little bit early because one was having trouble. So they did a emergency C-section. My granddaughter, grandson was fine, granddaughter not so much. And she had difficulty eating feeding for the first probably 8 to 12 weeks. The day she came home from the hospital after being in the NICU, she had a choking episode, and I happened to be the medic on duty and had to end up having to respond to my own grandchild's call. It was actually my mother-in-law overreacting, but it was still kind of scary knowing that she was premature, she was smaller, and she was having trouble swallowing appropriately, and getting formula or breast milk into the lung tissue can create a problem, obviously, for breathing as well as the development of the lungs. Again, most episodes are benign, but the younger they are, the more problems that persist, especially when it comes to airway and breathing. Persistent vomiting is a warning sign of an underlying problem. There could be something with airway, it could be something GI. A lot of babies may end up having some GERD or acid reflux. But containing any vomiting containing dark blood is often a sign of a life-threatening illness. It is in adults too, but in newborns it's especially problematic. Excuse me. Cause of vomiting, a presenting symptom may give a clue to the site of an obstruction or what the underlying problem is. Esophageal atresia, which I should have some pictures in here, I believe, here shortly, on different, sure what word to use here, problems that can present that will cause vomiting, that has the direct impact or direct result of how the baby has been growing. There could be a tracheoesophageal fistula. There could be problems with an incomplete esophagus. It could be a problem with the lower end of the airway. So excessive frothing soon after birth would indicate some kind of blockage or problem within either the trachea or the esophagus, and can also lead to gastric perforation, which that is a whole other problem. Oh, here's what I was talking about. Normal anatomy. The trachea is more anterior when you're looking at a patient, more in front of or more anterior than the esophagus. The trachea has the hard cartilaginous rings, and the esophagus is nothing but soft tissue or smooth tissue. But then you look at the second, you have an atresia with a distal fistula, where actually there is a blockage of the normal esophagus, and it has grown over to the side of the trachea. Then you have a double fistula, or you have an atresia where there is no connection to the stomach. You have a complete separation with no involvement of the trachea, and then you have obviously the esophageal tracheal fistula that goes into the belly. So there are all kinds of problems like this that can come with the formation of babies, especially the more newborn they are, the more premature they are, the more problematic their airways and esophagus can be. I can tell you from personal experience, when I worked at Lifeline, I had to go to J.C. Blair Memorial Hospital up in the Altoona, Hollidaysburg area, or Huntington County area, to pick up a baby that had one of these. End up having to intubate this baby around the fistula, which was very nerve-wracking, but it was successful. Baby ended up having to be flown back to Hershey and had surgery and did well. But luckily, the ER physician noticed it. Pediatrician came into the ER, didn't recognize the problem, but the ER doc caught it, which was great. Pathogenic gastroesophageal reflux is reported prevalence in 2 to 10% of the population of newborns. Most commonly seen in infancy or right after birth. May vomit either immediately or a few hours after a feeding. It's kind of uncomplicated gastroesophageal reflux. So not uncommon until a baby kind of gets in their groove of how to eat and get sustenance the right way. So that's why parents are taught how to use for nursing mothers, how to have the baby latch on appropriately. And if the parents have decided not to do breastfeeding, then obviously using different types of nipples on bottles that is more conducive to the baby. They have slow flow, moderate flow, high or excessive flow or high flow nipples, depending on the age of the baby and their ability to get a seal and actually suck appropriately. So it's hit or miss. It's kind of a game until they get in their groove. Infantile hypertrophic pyloric stenosis happens in 2 to 4 cases out of 1,000. It's 4 to 1 more prominent in the males. 30% of them are normally firstborn males, and stomach muscles will contract 10, 15 minutes. Okay. But stomach muscles contract forcibly, almost causing vomiting. But this pyloric stenosis, the pyloric muscles get stenosis and they can't really function appropriately, and the stomach muscles start to contract, which then obviously forces whatever's in the belly out. Malrotation, congenital abnormality or anomaly of the midgut or the belly. Small bowel is found on the right side of the abdomen instead of where it's supposed to be in the left side. It can create malnutrition or something we also call an intussusception, where the bowel, whether it be the large intestines or the small intestines, actually are twisted or turned the wrong way. It can be corrected with surgical procedure. It happens in 1 out of every about 500 births. Meconium plug, something that is specific, can be specific to Hirschsprung's disease, which is something that is seen in this area more in the Amish population. The last segment of the colon fails to relax, and usually there's a history of not passing any meconium within the first 24 hours of life, or not having the first bowel movement. You can see on the left side of the screen the normal sigmoid colon and rectum, where we have the Hirschsprung's disease on the right, where there's this like inflation of the descending colon with then constricted area of the sigmoid colon and the rectum that is contracted, if you will, and the any kind of excretory or excrement or any kind of bowel or stool that's stuck in the colon could then cause sepsis, can have a bowel perforation, and can lead to death. Additional causes of vomiting in conjunction with asphyxia, meningitis, and hydrocephalus. Often sudden, unexpected, and forceful vomiting may be accompanied by persistent irritability, which usually indicates pain. Initial management steps include obviously airway, breathing, circulation, suction to clear the vomit. Antiemetics should not be administered in the field to newborns unless otherwise instructed by medical command. Once transport has started, we need to place the newborn on their side, almost like in a rescue or recovery position, and maintaining their airway. Diarrhea, excessive loss of electrolytes and fluids in the stool. The normal number of stools or bowel movements a newborn normally has is 5 to 6 per day. If it's getting higher, up into the 8, 9, 10 range, expect some dehydration. Prevalence is higher in infants that are attending daycare centers. That's usually because of intercontamination between one child and the other. Causes of acute diarrhea include viral infection, which is the most common cause, gastroenteritis, lactose intolerance, neonatal abstinence syndrome, thyrotoxicosis, thyrotoxosis, and cystic fibrosis. Severe cases have a combination of signs. They usually look ill. They have poor color. They just look kind of drawn. Poor vital signs. Capillary refill can be greater than 2 seconds. Dry mucous membranes. Crying without tears. Weight loss and low urine output. And with urine can also have a stronger smelling concentration. Assessment includes, which is also vitally important when you're doing your assessment with parents and interview with parents or the caregiver, is estimating the number of stools that babies have had through the last 12 to 24 hours, if they've had decreased urinary output, what their degree of dehydration is. Oftentimes, one of the things we learned at Hershey was weighing diapers, or looking at the number of diapers provided in a certain amount of time. Obviously, management of airway, breathing, and circulation is vitally important, and fluid therapy may be indicated. I am not one, and I'm certainly not going to tell you this is what I expect you to do. But although protocols do talk about starting vascular access on kids and giving them fluid, but I'm here to tell you that unless the baby needs it, I would avoid any kind of invasive IV starts unless you feel that they are dehydrated and need to have fluid. Vascular access in little ones can be somewhat difficult. So, and there's no reason to get them more upset than they need to be. Common birth injuries in a newborn. There are avoidable and unavoidable injuries during the delivery process. Usually there's an average of about 5 for every 1,000 live births. Most are self-limiting and have a favorable outcome. However, this does account for 2 to 3% of all infant deaths. So if you're sitting up late at night and you hear those ambulance chasing lawyers that are out there asking to call in for birth defects and birth injuries, that's what they're looking for. These kids that have died due to birth injury. Causes are infant size or position of the baby. Babies are breech, especially if you have an arm presentation with a head, just one arm or both arms before the head. Oftentimes the shoulder girdle or the arm and shoulder and head cannot be born and cannot present at the same time. And that can cause all kinds of musculoskeletal injuries, can cause nerve damage, can block off an airway, can cause a prolapse in the umbilical cord. Prima gravida or prolonged labor, a cephalopelvic disproportion, or the child has a large head compared to the rest of the body. Rapid labor, where moms are doing fine and all of a sudden they go into labor and they're having super forceful labor and babies are moving quickly, faster than the cervix is able to open up and separate to allow baby to pass. Obviously, abnormal presentation, a large size, prematurity, and again, low birth weight. Various injuries include we call a caput secundum, is actually the medical term for a cone head, if you will. Sometimes will develop as babies are coming through the birth canal and they have a cone shape to their head because their head is actually forcing the cervix open from the inside out. This usually will fix itself within a few days, but there's a marked noticeable difference and the babies will not stay like that. It's one of the reasons why the bones in the skull are not as fused right away at birth. A cephalohematoma, or a head bleed, if you will, or a superficial head bleed. You can cause linear fractures of the skull, brachial plexus injuries, and branches of the facial nerve can have problems because of not enough area to be born. Diaphragmatic paralysis, laryngeal nerve injuries, spinal cord injuries, clavicle dislocation, that is more common than not. Long bone fractures, especially in the humeral bones, and intra-abdominal injuries. Family and transport considerations. It is always suggested that you go to the closest appropriate facility. For those of you that do deal with the Amish population or other populations similar to the Amish, many of them already have predetermined hospitals they like to go to. Here in Lancaster County, up until the advent of what used to be Heart of Lancaster Regional Medical Center that replaced the old community hospital, most Amish here in Lancaster County used to like to go to Community Hospital of Lancaster on the east side of Lancaster over by Conestoga View. When that facility closed, they started going up to Heart of Lancaster, which is now UPMC Lidditz, and many babies are transferred now to the neonatal intensive care unit and pediatric OB units at WellSpan Ephrata Community Hospital rather than Women's and Babies Hospital here in Lancaster. But the bottom line is we still need to transport to the facility the parents tell us to within reason, even after giving them all the information that they may have delay in care due to longer transport. They may not have the facilities necessary to deal with their child's issues that we're presenting. However, I will tell you that the NICU at Ephrata Community Hospital or WellSpan Ephrata Community Hospital is one of the best in the region. It's comparable to Harrisburg Hospital, comparable to Hershey, comparable to Women's and Babies. It's not quite as big as the others, but it fully staffed with more than capable neonatologists, NICU certified nurses, and the best equipment around. I've transferred patients out of there back to Hershey and never had a problem. It is important to make sure you keep ongoing communication with the family. This is their brand new baby. They need to know what's going on. They deserve to know what's going on. Don't be specific about any kind of survival statistics or anything, just giving the facts of what your assessment and treatments are for the presenting problem at the time. We don't want to give false hope, but we also don't want to lead them down a path of thinking that their baby is going to die. So it is important, vitally important, that you have open communications that are factual. New and more sophisticated techniques for care, especially for premature infants. There are expert medical personnel. Women's and Babies Hospital has a perinatal response team. I know that we have already responded and gone to Women's and Babies, picked up a team and brought them out to the field. It doesn't happen often, but it's available. With these new techniques and these sophisticated teams, we see a significant reduction in mortality among high-risk newborns. The normal average community hospital usually cannot provide this type of care, and it's usually a regional center, like Women's and Babies, the Women's Place at UPMC Lidditz, Ephrata, Penn State Hershey, Harrisburg Hospital. I believe York, WellSpan York also has a specialty facility. And then there's a regional referral system. Obviously, the physician initiates a request for transport. It's chosen usually by the facility that is going to be accepting the child. Transport team is mobilized, equipment is assembled, team stabilizes the infant before transport. One of the first things I was taught at Lifeline was sometimes it's important to get the patient away from the problem, and sometimes the problem is the other facility. Not saying that it's anything that is intentional. It just could be that the hospital that the patient is in just does not have the capabilities to take care of the presenting problem, whether it be a newborn or some other problem for a child or an adult. But stabilization on the scene is vitally important before transport. Obviously, they do an assessment, they collect information and materials, and they head off to the tertiary care facility needed to take care of this child. In summary, intervention and resuscitation steps are extremely important. We want to make sure that we are doing things simultaneously. We are maintaining an open patent airway. We are warming and stimulating and drying babies. We are keeping them secure because they depend on us for everything. There are specific conditions that we went over. Prematurity and low birth weight are extremely detrimental to newborns, and obviously we also went over common birth injuries. Does anybody have any questions in regards to neonatology right now. Okay, then I'm going to give you guys a little break while we switch over. And let's see, what time is it? I don't even know what time it is.